Thank you very much for the kind introduction. It is really an honor for me to present today, and I wish to thank Professor McDaddy and the organizing committee for inviting me to present. The topic of my talk is Literature in JPGN and Other Journals in 2022. These are my disclosures. I also want to highlight that I'm not a subject matter expert on everything I'll be talking about, so please forgive any errors or oversights or leaving out important papers. Most of these papers are from GI journals and easily accessible. For infographics, which you will see in a few minutes, the citation is in the bottom left of the infographic. And please feel free to take photographs of slides if you wish. This is the outline of our talk today. I will be talking about various parts of the GI, hepatobiliary, pancreas organ system, and at the end also talk about some JPGN updates. JPGN, as you know, is the premier global journal of our community, and we are proud to be leading that journal and presenting work from the journal to the group today. We'll start off with inflammatory bowel disease. These are the 4 subject matter areas in IBD I'll be giving some brief presentations on. The first paper is oral manifestations and oral extraintestinal findings of pediatric inflammatory bowel disease. This is a review article published earlier last year in JPGN with beautiful photographs and can be a nice resource for you to have in your white coat pocket to teach residents and students and other learners. It shows the various oral and extraintestinal manifestations of pediatric IBD, all the way from lip erythema on the top part, all the way down to methotrexate-induced ulcers on the bottom right. So nice photographs and a nice tool to educate others. Showing the breadth and depth of JPGN. This is not really a clinical paper, but actually a histopathology and clinical paper. They took 138 children with granulomas or microgranulomas. So a granuloma is on the left side is a collection of several histiocytes that are well circumscribed, whereas a microgranuloma, as on the right side of the slide, is a poorly differentiated and collection of fewer than 10 histiocytes. And what these authors did was look at the clinical outcome of children who had granuloma and microgranuloma, as shown on this graph. The patients with microgranuloma are in the dark broken line, and those with granuloma are in the lighter colored broken line. Both of them were compared to no granulomas, which is a solid line. Patients without any granulomas avoided anti-TNF therapy more frequently than those who had granulomas or microgranulomas. The authors go on to conclude that microgranulomas not only are important, but they can also have clinical significance, such as shown in this paper on their ability to not be able to avoid anti-TNF therapy. And you should have your GI pathologist to report on microgranulomas if they do not already do so. This other paper from a database called the ProKids VEO IBD, very early onset IBD, looked at children, 101 children with VEO IBD between 2010 and 2013 who started anti-TNF therapy. So 55 of these 101 children started anti-TNF therapy within 5 years of diagnosis. And then they looked at durability and persistence of therapy and also response or loss of response. What they found was data similar to the adult or the older child data, where at 5 years after starting TNF therapy, about 55% were continuing to be on anti-TNF therapy, and those that discontinued it did it for reasons similar to older children, such as loss of response or adverse reaction. So this is an important paper highlighting not only the use of anti-TNF therapy in VEO IBD, but also that the durability of response and loss of response are similar in VEO IBD to regular IBD. And this is the slide that shows you the infographic with the citation at the bottom of the infographic. Finally, in IBD, I want to talk about obesity and its effects on surgical outcomes in children with Crohn's disease. This was a study of over 1,200 pediatric patients with Crohn's disease who underwent surgical management and were followed up for 30 days post-operatively. What they found was that children who had obesity had a twofold higher risk of readmission and an 80% higher risk of infection compared to children without obesity prior to the surgical intervention. So again, shows that obesity may not only may have other issues, but also it affects the surgical outcomes and recovery in patients with inflammatory bowel disease. Moving on to the liver, there are two things I'll talk about: epidemiology and therapy. This is a study from Canada where they looked at about 3,000 children with cirrhosis from 1997 to 2017. Interestingly, they found that over this 20-year period, as shown on the graph, there was a four-fold increase in the incidence of cirrhosis in these patients. So really a marked increase, and it was more so in infants and teenagers, to the point that they do not know why this is happening. Is it all NAFL or some other reason? But it is to the point that a child born in 2010 was twice as likely to have cirrhosis compared to a child born in 2001. So quite in sobering and thoughtful data for us to think about why is there such an increase in cirrhosis in Canada over a 20-year period, and what the implications might be in children long term. Talking about long term, I want to talk about IBAT drugs. IBAT is ileal bile acid transporters, and IBAT inhibitors inhibit or interrupt the enterohepatic circulation of bile acid, resulting in lower pruritus and lower serum bile acid levels. There are two main drugs that have been studied: maralixibat, the study was in Alagilles, and odevixibat, which was in PFIC, progressive familial intrahepatic cholestasis. We'll talk about the two studies in the next few slides. The first study is on maralixibat in children with Alagille syndrome. They had 57 children who were on maralixibat, and they looked at their data, including the itch score, the clinical symptom score, and serum bile acid, as shown in the yellow box. And all three parameters were improved at week 46 or week 48 compared to baseline in children who received the drug. The other study looked at odevixibat in PFIC. It was a placebo-controlled study that looked at pruritus score and serum bile acid scores, compared those who got drug to those who were in placebo, which is in blue. And as you will see, those who got drug had more improvement of the pruritus and better serum bile acid levels compared to those who got placebo. The authors go on to conclude that these drugs could be a game changer and help address some of the unmet needs in patients with these inherited liver diseases. Talking about inherited liver diseases, this looked at the neurodevelopmental outcomes in children with inherited liver diseases of Alagille syndrome, alpha-1, and PFIC. They administered them a scoring system known as full-scale IQ, and a score of less than 85 is abnormal. What they found was that a decent number of children with these conditions scored poorly on FSIQ, especially those with Alagille syndrome. And some of the factors associated with low FSIQ were malnutrition, parental education, and liver disease severity. So the question raised, this paper raised the question that if we are able to decrease the liver disease severity in patients with such conditions by using drugs like maralixibat or odevixibat, will it improve their neurodevelopmental outcomes? More studies for future. So moving from neurodevelopmental outcomes to neurogastroenterology, I will talk about two specific papers from JPGN. This paper looked at ways to start a neurogastroenterology and motility program. This shows how to develop a business plan and the logistics of getting a clinic started, including physical space and equipment you might need. And this box in green shows what your patient flow could look like in such a clinic. So all the way from referral to results to long-term follow-up, what could your clinic flow look like? You all are very familiar with achalasia and the in technology known as FLIP, which looks at esophageal distensibility as shown on this slide using FLIP technology. This paper from Johns Hopkins looked at FLIP in children under the age of 5 years and over the age of 5 years. And they compared the two groups. Interestingly, they found that the two groups behaved similarly. There was no increased risk of adverse events or median procedure time or other issues using FLIP in children under the age of 5 years compared to those ages 5 and older. We'll now flip to the new JPGN section. About a year ago, we were super proud to start a new section in JPGN known as endoscopy and procedures, and several papers have been published in this new section over the last year. The first was this supplement known as Penguin or Pediatric Endoscopy Quality Improvement Network, which was a joint study between the ASPIGAN and NASPIGAN societies and was supported by ASGE and the Canadian Society for Gastroenterology. This was truly a labor of love of many individuals from 31 centers in 11 countries who did a very deep literature review to come up with a set of guidelines to improve quality of pediatric gastrointestinal endoscopy. They came up with 4 domains of pediatric endoscopy, including endoscopic facilities, procedures, training, and patient experience. Based on their data, they suggest that there are 30 elements that should be mandatory part of an endoscopy report. And to move the field forward, they suggest 3 key quality identifiers that we can start off with, including cecal intubation rate, ileal intubation rate, and adequate bowel preparation. So these are some of the key quality indicators one could start using to help move the field of pediatric endoscopy forward. The other interesting paper in JPGN was looking at safety and the quality of as a quality improvement project, was looking at factors associated with extended fluoroscopy time during ERCP in children. So they took over 1,000 ERCPs in over 800 patients from 15 centers. And then they examined the factors associated with extended fluoroscopy time in children, which were history of chronic pancreatitis, ERCP being performed by pediatric GI under supervision of adult GI, difficult ERCP, and ERCP at non-freestanding children's hospital. All of these factors were associated with extended fluoroscopy time. Obviously, fluoroscopy is increased radiation, and hopefully with this data, one could start moving the needle in a different direction, in a better direction in children undergoing ERCP and their outcomes. From ERCP, we will go to pancreas, and we'll talk about pancreatitis and quality of life and pancreatitis and surgery. This paper in JPGN looked at over 360 children with acute recurrent pancreatitis or chronic pancreatitis and looked at their health-related quality of life indicators using physical and psychological parameters. They found that the physical quality of life was worse with emotional behavior problems and abdominal pain. And similarly, the psychosocial quality of life subscore was also worsened by emotional issues and constant pain. These indicate that if we are able to address these parameters early on, at least assess for these and intervene if possible, we could improve the quality of life of our patients with chronic pancreatitis or acute recurrent pancreatitis. Sometimes we have to consider surgery in children with chronic pancreatitis, and this is a nice review paper, a guideline in JPGN that talked about the surgical management of chronic pancreatitis, including in this figure, a procedure known as total pancreatectomy with islet autotransplantation, TPIAT, where the pancreas is taken out and the islet cells are infused into the liver through the portal vein. They give a nice table on criteria to be considered when considering TPAIT in children. And there's a very nice algorithm on operative decision-making for chronic pancreatitis, starting off with the pancreatic duct size and what are the findings on imaging, going to TPIAT or post-op procedure or Whipples. So it's a nice algorithm to get started when considering surgical management for a patient with chronic pancreatitis and how to start the journey and the discussion with the family. They took their data and they published short-term outcomes in adults and children undergoing TPIAT. They looked at various parameters as shown on the left side of the table, and then they compared adults and children. What they found was many of the outcomes were similar between adults and children, except that children had a longer length of stay after the procedure. However, their readmission rate was lower compared to adults, and their risk of portal vein thrombosis was also lower compared to adults. Those are the p-values in bold. They go on to conclude that pancreatectomy, while the techniques may differ between children and adults, the islet yields are higher in children, and the children have lower readmission rate and lower rates of portal vein thrombosis. We'll talk about a paper on luminal disease and a paper on excess calories on nutrition. So this is on eosinophilic gastritis, looking at a scoring system known as EG-REFS, Eosinophilic Gastritis Reference System for Endoscopy. This system looks at various endoscopic features of eosinophilic gastritis, including erosions and ulcers, as shown on the bottom left of the slide, nodularities, as shown on the top left of the slide, and thickened folds as shown on the middle part of the left side of the slide. They looked at various endoscopic features and their frequency, and then they correlated this with the physician global assessment of endoscopic severity and found that the Spearman correlation was very significant at 0.84 between the physician's global assessment and the composite scoring on the endoscopic scoring system. I am certain we'll be hearing more about EG-REFS in the coming years. This paper in JPGN looked at children or adolescents who were referred for laparoscopic sleeve gastrectomy. 352 children were referred to for surgery and underwent follow-up for 2 years. Out of those referred, 79 patients, which is 22%, underwent the surgery within 6 months of referral, which is in green. And those who underwent surgery had improvement, as we would expect, in their sleep apnea and diabetes and hypertension and their metabolic profile. However, I think the bigger message in this paper is that 3/4 of the patient, 273, the vast majority who did not go through the surgical procedure. And not that we want to do surgery, but if a surgery is recommended, I think it is important to learn what is the barriers perceived by the patient on proceeding through with the surgery if it has been medically recommended or suggested. We'll also talk about environment and our health. It is important we talk about GI and environment and climate change. It is something real that is happening in our lives. A typical patient in the US generates about 20 kilograms of waste a day. The healthcare in the US generates about 11,000 tons of hospital waste a day and 4.3 million tons a year, and that is just in the United States. This review paper looked at the global rates of pediatric IBD and effect of our environment on it. They found that there was increasing chance of IBD being affected by pollution and urban living and poor air quality, and potentially decreased risk of IBD in rural environment, low pollution, and better air quality. This is a joint paper from the British Society for Gastroenterology, British Liver Society, European Liver Society, and American Liver Society, showing the importance of climate and environment on liver disease. So even though in the clinic we see a patient with the liver problem, the issues are that there are a lot of things that have happened in the background leading for the patient to come to our clinic. And if we don't address those issues, we will be putting our head in the sand and not really paying attention to what was the basic reason why the patient is ending up where they are. And at the beginning and then at the start of all of this, you will see climate crisis and weather events are one of the major criteria resulting in these downstream events of issues resulting in increased burden of liver disease. Talking about that, we have to play our part in environment. And this starts with reusing some of the things we do in endoscopy, recycling, and even reducing the amount of material we use during the endoscopy. This review paper published in many GI journals last year has suggest ways we can decrease waste during endoscopy. And because at the end of the day, we have one earth only, and it is our collective job to protect the environment the best we can. At this point, I'm going to switch gears and talk in the last few minutes about JPGN and some of the new initiatives you will see in JPGN. If you go to the JPGN website, www.jpgn.org, you will see a nice image carousel, which an image changes every few seconds. So that is a nice interactive feature in JPGN website. Along with, you will see something called the quick poll, where there'll be an image, a question, and answer options. You can pick up an answer, submit the answer, and see the results in real time. And if you scroll down on the website, you will see the explanation for the answer. This is, again, a self-assessment tool we have provided for our readers and our community, along with changes to our table of contents on the website, which are not only text, but also some images with the text to give a break to the eye as you look at the table of contents. Finally, you will see on the website what we call the podcast. These are podcasts done at different frequencies. Some are monthly, some are quarterly, on papers published in the journal. And you're welcome to listen to these while you're driving or exercising or at leisure or in the car. Obviously do it in a safe manner whenever you do it. But, you can listen to podcast on some of the articles in JPGN. Every month, I hope you are getting an email known as post-publication materials. We send it to Professor McDaddy, and I think he then sends it to the society, the Pan-Arab Middle East Society. This email on a monthly basis has various self-assessment and teaching issues in it, including CME material. You don't have to sign up for CME, but you can just do the questions as self-assessment on articles, and those are free to access. Infographics, as I've shown, you can use this for teaching and lectures and informing the residents and fellows and students. And also the quick poll that I showed you is also on this email that comes every month. If you do not get it, please let me or Professor McDaddy know, and we'll be happy to include you in the mailing list. And it's free. Each year we talk about the editors-in-chief of JPGN publish about the highlights in the journal. Professor Belli is the editor-in-chief for the European office, the Eastern Hemisphere office of JPGN, and I lead the Western Hemisphere or the North American office. So look out for this. It comes out in June, July of each year. And also we started this new section known as endoscopy and procedures that I just told you about a few minutes ago. Our impact factor has been the highest ever. And last year, we were excited that our impact factor was 3.315, which is the highest it has ever been. And we hope to even make it even higher over the coming years. To further engage our community and our readers, including our international readers, our publisher, Walter Kluwer, has kindly given an opportunity for an yearly online-only subscription to JPGN at a special rate of $100. So with $100, you can access the journal entirely for an entire year online, which is less than about $10 a month. It's about $8 a month. So I would strongly encourage you to subscribe to this. Make sure you use this opportunity. And if you need this to be sent to you, let Professor McNady or I know, and we'll be happy to share this again with you. Finally, these are some of the individuals who work with me as the associate editors in the North American office, and I'm very grateful to them. And to these individuals who are the section editors for JPGN, again in the North American office. This is our editorial board in North America. And this is a journal cover from a few months ago showing an interesting polyp on it. So happy to take any questions or concerns, but thank you so much for your time. I really appreciate this opportunity to present to the society today. Thank you.